when we look at things over time, a lot of things don't change, you know, for people living with dementia. And I think that was quite an interesting finding for us. It's a bit different for carers. We know carers' stress increases, but I think that's quite an interesting finding in itself in terms of looking at the longitudinal side of the data.
Yes, I think we thought about that in the first end of Ideal, didn't we, about how we might have expected to see more change and we didn't. Yeah.
Oh dear, I was hoping to be at the end when you're V for Victor. You're always last and you can say everybody's covered my points. So I guess for me, one of the interesting things, and it reflects my own interest, was the relationships of the dyads, how the loneliness of the person with dementia could influence the well-being of the carer, and how the isolation of the carer could influence the well-being of the person with dementia. So for me, the interesting part, or one of the many interesting parts, was looking at the dyad, so the caring dyad, predominantly married couples, but not exclusively, and how the experiences of one can influence the other member of the dyad. And perhaps that gives us some different ways of thinking about how we might intervene to enhance the well-being of both.
So for me, it was, I was going to have the not moving very much because it was my statistical models that were trying to make people... It's all yours. But for me, I think it was, what does that then mean? And thinking about the differences that we saw in people at their diagnosis, very close to their diagnosis, and the differences in those larger cross-sectional differences that we saw and the implications that had for people when they get that diagnosis of dementia, that actually do the clinicians really understand the differences that they see in the people in front of them when they give them those diagnoses. They are all so very different to where they are. Yes, there are similarities across different sorts of subtypes of dementia, but actually, and as Linda showed earlier about the inequalities that you see, that are inequalities that just mirror inequalities you see within the carers and the people with dementia and people who do not have dementia in similar ages, and that's frustrating to see. But actually, it gives you an indication of this is where somebody now is, and what we now need to do to keep them there. You can't go and turn back the time to a time that before they had the dementia, because that's not what this study was about. But actually that you do have a chance to say, well, this is where they are, and this is for some individuals where we can keep them and maintain them at that point, rather than the fact that, yes, what we expected was more of a decline in a lot of individuals a lot quicker.
And that's good news, really, isn't it? But if we can spot those things at the time of diagnosis already and then work with them, that's good news. It's not inevitable decline.
Yes.
Yeah.
So I'm Martin Knapp, based at MSc, and with Kate, who's there. Do you want to just wave your hand, please? I don't know. So one of our main contribution to Ideal was looking at some of the economic aspects. And one of the things that interested me, surprised me, depressed me about Ideal was how few services people are able to access and are using. Most of the evidence we had prior to Ideal came from randomised controlled trials, and they tend to be a bit more optimistic about what people are getting, probably because they're recruiting people who aren't as typical of the people with dementia and carers that are in Ideal. So I think it's that relatively low level of support that many people are getting in their lives, despite often having quite considerable needs for support. There's people with dementia and carers.
And at the time of diagnosis already, as we've seen.
Yeah, exactly.
Yeah. Okay. So lots of interesting findings, some good news, some maybe less good news, but perhaps things we could do something about. I'd just like to focus a little bit more on relevance and then how we can use these findings towards making changes and improvements. So I wondered if you could just sort of think about where you feel the biggest relevance is for policy or practice in health and social care. You don't need to. You can pass the microphone if you want to break.
I did threaten to Sophie and Robin. I say, "Well, come on, you're in DHS."
Yes, just do come and join us. That would be a bit mean for them.
But I think it is. I think the things we've just been hearing all of those things have policy implications. So it is about, for example, thinking about the person with dementia and the people that support them as a dyad, because they're so interconnected, so that's one thing. I think it is about the support that people get. What we heard earlier was about people often, and my father had Parkinson's dementia, my mother was mildly cognitively declining at the time she died. It was finding those support for those people. It's very difficult to find your way through care systems, through local systems, to find the right support that people have. So I think there's things that could be done. It doesn't have to be high level expensive, it just needs to be accessible and make people aware of what's available to support them.
For me, I think it's about where we were talking about people with dementia, not just people with dementia. They're people with dementia, they might also have diabetes, or they've got dementia, they've got arthritis, they've got dementia, they've got something else. And the healthcare systems might be very accessible for people with dementia to go to a dementia clinic. But actually, are they very accessible for people with dementia to go to their other health clinics and to get the proper the proper support that they can for other conditions? And that's oftentimes when you hear about, you hear, well, they got dementia, and then that's that. You then don't get the other diagnoses that come after dementia in the same way as other people do when they're getting older, as other conditions come to the fore. And actually that's also a really important policy, that we have a health system that's very siloed in different diseases, and that's the same for every person. But actually for people with dementia, that causes additional barriers to them getting the proper quality of care that they need for everything else that's going on in their life, as well as the dementia at the same time.
So I'll answer a slightly different question, because I'm a good politician. So I have a background in geography, so I think one of the areas that emerged from the findings, I think Linda mentioned briefly, is about where we live, people with dementia and people without dementia. And some of the findings from the study showed that access to blue-green spaces for people with dementia is linked with better well-being, as it is for the general population. So for me, thinking about how we can make those spaces available to people with dementia, and then we make them available to everybody. And also some, some other work that we did is linked to the idea of dementia-friendly communities. So carers who felt that their role as a carer was valued by members in their local area, neighbourhood, community, whatever you want to think about it, had better well-being than those who didn't feel their role was appreciated. So I think there's some things we can do at community level to value people with dementia and their carers and make things accessible for them, which may not be particularly resource intensive. So thinking at big policy level, but also, isn't it, think local, act global, or in this case, act local and think global.
I think it's kind of often wrongly be assumed that the care provided by family members to somebody living with dementia is free.
Yeah.
Because it's provided by, but as Martin and Kate shown, that there is an economic cost to family members providing care for various reasons. But there's also a cost to the carer themselves. We've seen in our data about how carer stress can increase over time. So we know that the impact on the family carer themselves. But we've also seen within the ideal data the importance of that, what we call the dyadic relationship, that relationship between the person living with dementia and that person who's providing care or support for them. We've also seen about how they can influence each other's well-being. And that really highlights the point that to get support right, we need to be supporting both people. Because if we only support one and not the other, we're not having that benefit that we expect, and that's one of the big sort of findings for me out of ideal, and where we can see difference. And picking up on Martin's point as well, you know, one of the amazing things that come out of ideal is our banners. You all saw the pictures, and the one that I use in my teaching a lot is the one that shows how accessing support services in Maze. That is very difficult to find that support. Yet we know when people get the right support how much of a benefit it can have. So I think that's really where the difference needs to be made is recognising the importance of that dyadic relationship and supporting both members and enabling them to get access to the right level of support.
Thank you. A lot of really interesting points there. I wonder if we could just shift gear a little bit as we're researchers to think about, well, two things really, in terms of often as researchers we're trying to aim as well to build capacity so that there's better potential to do research and gather evidence. And so I'd be interested if you could think a little bit about how IDEAL might have helped to do that and how we can best build on IDEAL in future work in a research perspective.
I mean, I think about the IDEAL study, I think of capacity. I'm looking at the room, people in front of me here. I'm thinking about all the people I've talked to that I worked with over the years when, even before IDEAL was funded, we were thinking about this back probably about 2012 and the huge range of impact. And I think the building of capacity has not just been within ourselves as a research team, but also more broadly with the Always group we've been working with. And I think one of the huge benefits of the IDEAL programme itself, although it didn't feel like it at the start, was it gave us a bit of a chance to breathe, which, although it was a very busy study to set up, but it's enabled us, because of the longevity of the funding, to do these creative outputs. And so I see capacity building as not just within the team itself, the research is connected to it, but the fact that we're able to get our messages out in an accessible manner to other people as well, who can learn from our experiences and take our learnings into developing their own research and improving things, the way they do things, the way we've demonstrated how the Always group works so successfully. That's a great example of practice to pass on to other people. So I'd like to think that the capacity building that we've had is not just within ourselves, but as I say, more broadly reached out. So many people know about IDEAL and the work that we do.
You don't have to comment on everything if you don't want to.
No, I was going to say a different sort of angle. I use some of the resources from IDEAL in my teaching, and particularly the film, A Life More Ordinary.
No, it's well turned upside
down.
Well
turned upside down, sorry. I'll get it right before the project ends. And I'm not a very good teacher, so I use all sorts of resources to cover my inadequacies. But I teach mostly healthcare students, so physios, OTs, nurses, public health practitioners and medics. And I think they have very fixed ideas about people with dementia, working with older adults, and I think using those materials with them has had an impact to some degree in contributing to their thinking about older people with dementia as people first, and the dementia following. And I also refer them to Tom Kitwood in I'm hoping for royalties from that soon. So I think we've been able to have, through teaching as well, I think all of us have had an impact on students which may not be realised for some time, but hopefully will contribute towards clinicians who have a more enlightened view about dementia. Even if one student out of a class of 150 changes their ideas and works with older adults with dementia and carers, then that seems to be a very worthwhile outcome.
Can I just tell a little story there? We had when we did the play,
yeah,
and it was being filmed, we presented it to sixth form drama students, and one of them afterwards said, "I thought dementia was something that came on suddenly, and then it was suddenly really, really severe," and he didn't know that it was, and it was just very basic knowledge that. Anyway, go ahead.
I think the law of unintended consequences in a positive way.
Yeah.
Do you want to ask a different one, or do you want to?
I don't like. Which question would you like?
Then said we didn't have to answer it all, and then
which question would you like?
Just because you had the microphone, really. I don't know. Did you want to comment on capacity building, or would you like to talk about something else?
Honestly, as a study like this, it keeps statisticians going for decades. So the capacity in terms of that is wonderful. I think that is the other thing, is that even though we're celebrating IDEAL now, and actually the study itself, as you say, is going to working it through to the book, the data is there, and the data is a huge, huge resource for data. So the work that people will be able to do using the data will far exceed, hopefully I'll have retired, and the data will still be, people will still be trying to find a decline somewhere in the data.
With new methods, you know.
So I think that is also, it's not just about the capacity, and working with dementia wasn't always sexy, as you know, the people from the Alzheimer's Society, you know, researchers steered away from working with dementia. It was too difficult. If you wanted to make a name for yourself, you didn't move into working with dementia. And I think here, with the IDEAL study, you've been able to show that you can get good quality research in dementia with people with dementia, not just before people get dementia, but after people have got dementia and their carers, and made it possible for people to start to have a career in research, working with a data set that is high quality. There's a large number of people. I like large studies, and so therefore, you know, and that will continue to give that for the next generation. As you know, Christina said, she uses it in her teaching. Project students have used it to analyse. Started off to find the joy of working with real data from real people to make real answers to real questions, and I think that is a legacy that will continue.
I'm
going to share an anecdote. So my father had Parkinson's dementia, and it was 8 years ago. He was in my house, and one of my grandsons was there. He was 6 at the time, and my dad was having just a bad day, and the 6-year-old grandson hadn't seen him behave like that and didn't quite know what to, and so asked what the problem was, and asked what was going on. So we explained it. And he was very interested to learn more about dementia. And I was reflecting that, you know, when I was 6, which was about 30 years before that, when I was 6, you didn't know anybody with dementia. Partly people didn't live very long, and if they did live long enough to get dementia, they were locked away. But I think today everybody knows somebody with dementia, at least one person with dementia. And what IDEAL can do is offer evidence and information to help people understand what it means. And I think that's the play and the film and the leaflets and the YouTube and everything else. And I think that ability to communicate in an evidence-informed way is really important.
You're right, thank you. And just to finish very briefly, one thing from each of you, if you can, if there is something that you most enjoyed about working on IDEAL.
I quickly say I've enjoyed. I mean, it's been intellectually rigorous, and that's been great. But it's also surprisingly, there are people here today that were there at the very beginning, and the team has stayed very stable. I think that's great, and that's an indication of really good teamwork. So I like that.
One thing that we
enjoyed. If there was something you enjoyed. She's a statistician. Can't help it.
I enjoyed it all, but I mean, I like the challenge, and I like the challenge of trying to find good, rigorous answers to questions. And IDEAL has certainly been a challenge to find good, rigorous answers to questions.
We did give you a challenge.
And so I've enjoyed it all. It's great to work with such a wonderful group of individuals that we've got here. To have the long-term funding, so we didn't have to worry all of the time where the next funding was coming from, and actually you could then just get on with, you could appoint good people and know that they would have a longer-term job to actually develop, understand the study, to really be able to get the best out of the data. And I think, I have enjoyed it all.
I'm going to lower the tone, as ever. Visiting exotic and interesting places to present our findings to the wider community.
Thank you.
I mean, I think the best thing about IDEAL is the team. It's everybody here. I mean, it's been such an amazing experience. You know, if you got where I was when this project started my career, you know, to have worked with a group of people for such a long length of time, and that is a rarity in research. And I think it's a huge joy about the fact that so many people have come along today, to celebrate the study. And I think that is the best thing about IDEAL at the end.
Thank you very much. Okay.
You want to hear that?